Dear colleagues, thank you for selecting our work to present here. This is like an audit of how we are doing in our clinics. So we have a long story now for atherosclerotic cardiovascular disease in SLE, starting with Murray Eurowitz's seminal paper, and then many other publications show the importance of this problem in the prognosis of our patients. A recent systematic review of more than 3,000 papers and coming up with 28 shows that at least double the risk of cardiovascular disease in SLE compared to the general population. And it also shows that both traditional and SLE-specific risk factors are important. If you look at few tables in this publication, this is about myocardial infarction, and we see that it's more than general population. The risk is higher in older patients, but very high in young patients. And if you look at cerebrovascular accidents, it's again higher than normal population, somewhat trivial in older patients, but definitely higher in younger patients. So we would like to learn how we are doing, if you like, badly in our clinic. So more than 300 consecutive patients. These are the current attenders of the clinic, minimum of 6 months follow-up. There was an assessment with predefined protocol, interview with the patients, all the health records, so we updated our database. We know the demographics, clinical features, history of cardiovascular disease and traditional cardiovascular risk factors, including metabolic syndrome. And also we assessed the prevalence of metabolic syndrome in this cohort as well. And we did a univariate and multivariable analysis. So this is our usual attenders with almost 90% female. Half of them had renal involvement. The mean age is around 40. Mean disease duration is around 9 years, more than 2,000 person years of follow-up. And some of them had damage with a mean damage score more than 1. If you look at the main factors that we investigated, we found that 15% of the cases has some kind of cardiovascular disease, more than 10% had coronary artery disease, around 5% has cerebrovascular events. And 40% of the cohort had hypertension and almost 20% had metabolic syndrome. In the univariate analysis, the usual suspects is there. I mean, hypertension, hypertriglyceridemia, and metabolic syndrome. But also we found that disease-specific features, some characters, are more prevalent than others in patients with cardiovascular involvement, which are pericarditis, cytopenias, neuropsychiatric involvement, and also some serologic features. Actually, all antiphospholipid antibodies, anticardiolipin IgM, lupus anticoagulant, and any antiphospholipid positivity increase the risk of cardiovascular involvement. We all like hydroxychloroquine and try to get our patients on it, but some of them somehow rejected it. So even in this cohort with a very high hydroxychloroquine usage, there is some protective effect of hydroxychloroquine in these patients without cardiovascular disease. And cyclophosphamide appeared as a risk factor, possibly reflecting the severity of these patients with cardiovascular disease. In the demographics, patients with cardiovascular disease are older and disease duration is a bit longer, but not significant. On the other hand, it's a bit circular, but they have a more damage. Cyclic damage scores are higher in patients with cardiovascular disease. But another thing is maybe reflecting the disease severity is they had more ACR criteria than patients without cardiovascular disease. So we did some multivariable analysis models. We can include the term metabolic syndrome as a whole. If we included it, it appeared as a risk factor, but all the other risk factors are related to the disease itself. In another model with a high correct classification, we just split up the metabolic syndrome and just use the components. So hypertension seems the usual suspect with other disease-specific factors. So we had a lot of limitations. These are the current attenders of our clinic. This is a selected group of patients, and we only count the clinical events. So we have no idea in this group of subclinical, for example, atherosclerosis. We didn't look at the cumulative effect of disease activity, although we couldn't find any relationship with the current disease activity. And again, it's very hard from this data set to extract the cumulative corticosteroid use, but we had a stratification of high dose and low dose corticosteroid takers, so we couldn't find any difference between these. Also, dosing and duration of immunosuppressives are not available, so we know that patients taking cyclophosphamide has a possibly higher risk of getting cardiovascular disease, but we don't know which dosage is important. We would like to have the homocysteine, vitamin D, sensitive CRP or cystatin C levels. We are working on the CRP. We got some data, but not yet available. So these are the limitations of this data set. In conclusion, even among current attenders, so they are not so bad, they are not so good, they are attenders in the last 6 months. 90% female with a mean age of 40. There's a prevalence of non-fatal cardiovascular disease of 15%. We got a study from Turkey, from our Heart Society, which has a prevalence of under 50 years, females 3%. This is a more than 10 years study, so it's maybe increased like Professor Petri mentioned, but it's again more than 5 times of these prevalences. So hypertension and metabolic syndrome expectedly were associated with cardiovascular disease, but disease-related clinical features like pericarditis, possibly reflecting the inflammatory burden, cytopenias and neuropsychiatric involvement, including antiphospholipid antibody positivity, were also associated with cardiovascular disease. In the univariate analysis, we also see, like others, the protective effect of hydroxychloroquine, even in this series of very high patients with a very high prevalence taking hydroxychloroquine. And the treatment of cyclophosphamide was a risk factor, possibly reflecting disease severity in these patients. Patients with cardiovascular disease was older, with a longer disease duration and high number of ACR criteria and significantly more damage. So we think that disease severity also takes almost equal importance with the usual traditional risk factors for cardiovascular disease in our population. Thank you for your attention.
The abstract by Dr. Inanc is now open for discussion. Can I start by asking, Inanc, can I ask you,
sure.
Actually, if we try to put together your paper and that of Michelle, some of the manifestations you show are really ones that you will score in the SLEDAI. So it could be just disease, you can put it together as disease activity.
Yep. I think current disease activity may be important. I think Michelle had a previous paper on it, current disease activity and current corticosteroid dosages, but we couldn't show the relationship in this population. Maybe the cumulative disease activity has an important. Our paper is about characteristics of the paper, not the daily disease activity, but general characteristics.